Hello, everyone. Thanks, Duran. Thanks for organizing this. So today we're talking about correction of deformities in the foot and ankle. So there are quite a few deformities that we see in foot and ankle, and you may see these in your physio rooms if people are coming in with bare feet. Here you see on the left-hand side someone at the beach. I think these are how thongs were made, just so they can wrap around the toes. Here on the right side, you see a severe cavus foot, or at least that's what it looks like. Some of these things are quite extreme. Here's a very severe bunion deformity in someone. And then some are quite extreme. This, you look on the left-hand side, this is an ankle that's been dislocated. And on the right-hand side, there is some clubfoot deformities. And, when you see these, you may not know where the deformity is. And this is the crux of our talk, is not to get intimidated by these, but to kind of think of them in a more methodological way. Some of these deformities you can see are more subtle. Here you see a bunion on the left-hand side, and on the right-hand side, someone with a flat foot deformity. And lots of people have deformities, even in these subtle amounts. And when do we address these with treatment? And when do we think of these things as normal? So, whenever we have deformities like this, we just want to go back to the basics. As Kwan said, we always want to get our history and physical exam, and that will give us most of our answers. We use with these investigations, and then that'll help us to determine the treatment. So with any of these deformities, it's always important to know that not all foot and ankle deformities need to be corrected. So conservative treatment may do very well. Unlike the deformities in the kids, which Chris showed you, which a lot of those need surgery to help the hips, in these people, they've been living with them their whole lives. So what's that one thing that's made it different, that's made it, over the edge where they needed some treatment? Patients are quite used to their own feet the way they are, so we can consider surgery when it's needed. We can also consider conservative treatments, which can also help people with their problems. So conservative treatment may include orthotics, custom shoes, redistributing the weight and the forces around the foot. You can use functional orthotics like the one on the top, where we see it helps to correct the deformity. Or you can use accommodative foot devices where it just accommodates or makes whatever deformity you're dealing with more comfortable. So in order to show how to best approach any deformity around the foot, I thought I'd go through one particular case which shows quite a range of different things. It'll help to demonstrate the concepts of correction. And the goal here is to correct the deformity, but also to try to preserve the joints and try to preserve the function and the movement as much as possible. So in this one particular case, this is a 36-year-old female. She had bilateral cavovarus feet her whole life. The left ankle just has been getting a little bit worse lately, and that's been giving her trouble. Now, in the further history for her, how do we get her back to normal? She played netball for 23 years with these feet. She's had lots of ankle sprains in the past, but that never stopped her. She's also a karate instructor. She's been training to get her black belt as well. So number one principle here is to first establish the problem. So we need to understand this baseline activity level. In this particular case, she's fairly high functioning, even though her feet have these deformities. She's lived with them her whole life, and she's learned how to live with them. She's only noticed the problem more recently. And so the goals here are quite challenging. We don't want to take away her passions of karate. And while she has deformities, what's the one thing that's made it different lately that's brought her over the edge? So you got to evaluate these things and determine where these deformities lie. And so in her case, there could be deformities in the ankle, the hindfoot, the midfoot, the forefoot. Where is the deformity? Is it in the joints? Is it in the bone? So we usually use our investigations to look at these things. Weight-bearing x-rays are really important for looking at deformities because this is how the foot lies on the ground. If anyone has arthritis, it'll narrow the joints. You'll be able to see that clearer. Plus, they're more standard, so you'll get a standard view that the radiologist knows how to do. When someone lies down, the foot can be going in any different direction, and it's not a standard. We'll also use CT scan, and we'll also use MRIs when we need to look at the joints, see if there's any arthritis. When they're in the rooms, when we watch them in the rooms, we can observe their ambulation. So here is this patient walking. You can see that left ankle just a little bit kind of goes a little bit into varus, a little bit of collapse. You can see both feet there have deformities, but the left one's bothering her more. You can see also the hind feet were stiff. The ankle movement was also stiff with limited dorsiflexion. And you can see that on exam, the left ankle was definitely more stable in my more unstable on my examination than the right side. So with weight-bearing x-rays, what you'll see here, the one on the left side is just a normal x-ray, and the one on the right side is an x-ray of this patient. And so what we'll first notice here, you can see there's talonavicular arthritis on the right side. Where are the deformities? So we want to look for the center of rotation axis. So we're looking where the deformity lies. You can see here in the first TMT joint, there's a midfoot deformity, apex dorsal. In this, you can also look, if in order to determine where, if it's cavovarus or if it's flat foot, there are different parameters to look at. So what this line is here is at the bottom of the first metatarsal. So if you can look at that right there, and then the next line shows you the bottom of the fifth metatarsal. And so in this patient, because it's cavovarus, these two bones are very much separated and there's a bigger distance between the two. So there's also something called Meary's line. So if you make a line along the longitudinal axis of the talus, it should go through the first metatarsal on the lateral view and on the AP view. And we'll show this to you on the left-hand side, but if you look at that line on the right-hand side, it goes through the talus. It's way above the first metatarsal. So the other thing you can look at is in the hind foot, and you can look at the calcaneal pitch. So this is the calcaneal inclination angle, which is much higher on a cavovarus foot than would be normal on the one on the left-hand side. So if we look on the left-hand side, our first TMT joint line is straight. There's no angulation. Meary's line goes straight through the first metatarsal, the longitudinal axis of the talus. The distance from the first metatarsal to the fifth metatarsal is a much more normal distance there. And the calcaneal pitch there is what you'd normally see if you look at enough x-rays, about 20 degrees or so of a calcaneal pitch, or the way the calcaneus sits on the ground. So when we look at the AP of this patient, what you'll also notice first, this is the Meary's line we talked about, where we go through the longitudinal axis of the talus, and you can see how in this patient, the talus is directed way lateral on the foot. On the right-hand side is a normal x-ray, and you can see that that line, if you make it through the talus, goes right through the metatarsal. You'll also notice the talonavicular arthritis that this patient has, and the joint is shifted laterally, and it's arthritic. And you can see that this one on the right is normal. So what about her ankle x-rays? These are the weight-bearing x-rays of the ankle. On the left-hand side is our patient. On the right-hand side is normal. So with your weight-bearing on the left-hand side, you can see that's the horizontal axis of the tibia, and you can see how the talus sits in varus or medial angulation. And you can see on the right normal x-ray, these things are meant to be parallel to each other. So this demonstrates that this patient has some instability of the lateral portion of the ankle, and maybe even a little bit of arthritic change on the medial aspect of the joint. The third principle, when we're looking at deformities, we want to establish whether the joints are fixed or whether they're flexible, and this will help us to determine what kind of corrections we'll make. So when we perform our physical examination, we assess the movement of all the joints. Are they fixed? In this picture, you can see this was a quite fixed deformity. Whether they're fully correctable, whether they're partially correctable, and whether there's arthritis in the joints. Can we save these joints, or are they arthritic and we really can't save the joint? So as an example, this is not the patient we're talking about, but this is just a different case for an example. Here's someone with hallux varus. In this case, the joint moved well, the joint was preserved, and so we wanted to preserve movement. So a soft tissue reconstruction would be something that might be better, or you can do osteotomies around the joint to try to preserve the joint. So in this particular case of hallux varus, this was flexible. So in order to preserve the joint was correctable, and a correction was made with a ligament reconstruction of the lateral ligament. And this helped to bring the toe back and preserve motion of the joint. As foot and ankle surgeons, we do a lot of bunion corrections, and with bunion corrections, we want to preserve the joint. These are flexible and correctable. So you can see here, we choose to do an osteotomy where we osteotomize the bone and shift the joint, and this helps to correct the joint. So another technique to preserve the joints. So when we do our physical exam, we want to determine what joints are correctable and what joints are fixed. So here we see another example. This is an ankle joint. The ankle joint moved, and the flexibility of the ankle was preserved, but the ankle's in varus and it's fixed. This is not a correctable varus because it's in the bone and in the joint. And so what you can do is perform an osteotomy around the joint to correct its alignment and help to preserve motion. So you can see that this, the tibial straight axis goes through, and you can see how the alignment of the distal tibia is angulated. And so in order to correct this, a supramalleolar osteotomy was performed. A cut was made in the bone, an opening wedge osteotomy, which realigns the joint. And you can see how the joint there is parallel now, and it restores the alignment. And even though there was some arthritis, this patient did very well because we're realigning the forces around the preserved part of the joint, which had good movement, and took away the patient's pain. So here you can see a fixed, this is an example of another ankle, a fixed deformity with a lot of joint degeneration and arthritis. And so this patient has arthritis in the joint, and probably a joint that wouldn't do well with any preservation. So in this type of patients, we can do an ankle fusion to fuse to get rid of the arthritis, give the patient a nice stable leg to walk on, and the correction of the joint can be made through the fusion site, which is where the center of rotation is, and this will help to restore alignment for the rest of the foot. So going back to our case, our 37-year-old karate instructor, she had a flexible ankle, it was correctable, and so in this case we could do a soft tissue reconstruction to help the ankle joint correct. So in her, I did an ankle stabilization using her ligament tightening reconstruction procedure. You can do an osteotomy if you want, but in her, she had good alignment, so a soft tissue reconstruction was adequate for her ankle. Now, in this case, she had multiple deformities. You saw her cavovarus foot is in the hind foot, and the hind foot was fixed. She had talonavicular arthritis. Okay, and she has a cavovarus foot, which needs correction as well to also help the ankle, which was unstable. If the cavovarus foot was left there and we just repaired the ankle, it would certainly stretch out pretty quickly, and so these things need to get corrected at the same time. So the tailonnavicular arthritis is not salvageable, so a triple arthrodesis was my choice here. So we want to do a triple arthrodesis, which corrects 3 joints in the hind foot: the tailonnavicular joint, the subtalar joint, and the calcaneocuboid joints. These joints work in concert to help the foot adapt to uneven surfaces with inversion and eversion. And so with a cavovarus foot with lots of inversion, we correct that, correcting the joints and their alignment to get the foot plantigrade. So here you can see the case with a triple arthrodesis. You can see the hardware used to fuse the calcaneocuboid, tailonnavicular, and subtalar joint. And what I want you to notice here is, remember Meary's line. We make a line through the talus into the first metatarsal, and so that deformity was restored now. She's got good alignment on her AP view at the tailonnavicular joint sites. Now, we showed you, if you remember, this patient also had a midfoot deformity as part of the cavovarus foot. There's a flexion deformity at the tarsometatarsal joint. This joint is preserved, though. There's no arthritis of that joint. The joint was fixed. You can't really correct it with any soft tissue procedure, but an osteotomy works really well. So a dorsiflexion osteotomy is what I chose for the midfoot. So you can see here in this diagram, you can see how a midfoot deformity happens. On the top view is the cavovarus foot deformity, and after correction with a dorsiflexion osteotomy. So it helps to lift the first metatarsal, realigns the foot, preserves the first tarsometatarsal joint, and also you can see the plantar fascia sometimes needs to be released in these patients because it's quite tight. So here you can see the first metatarsal osteotomy is performed. You can see the staple in the midfoot. You can see the better alignment of the midfoot. There was a triple arthrodesis, and on the lateral you can see how Meary's line is restored on the line through the talus into the first metatarsal. Also notice after this correction that the distance between that first metatarsal and fifth metatarsal is restored with better alignment and less distance. So this patient is now about 9 months after her surgery. She's doing very well. She's returned to karate. She actually got her black belt, and now she's instructing and very happy with the way her foot works. So in summary, it's important to locate where the deformity is in the ankle and foot, or hind foot, or midfoot, or forefoot. And the way to do that is best to use weight-bearing x-rays and determine where the deformity lies. The physical examination is really helpful to determine where, if these joints are correctable or fixed. We always can use non-operative treatment. These patients have had these deformities their whole lives. They're used to them. If it's some minor thing that's giving them trouble, sometimes orthotics or better shoes can help them. And then we sometimes do surgery to treat these. So thank you very much.